Hello, ladies, and welcome back to the Lube Tube. We are on episode 14, and this one is all about the pelvic floor and what it does for us as ladies. My name is Jeanette, and I'm a physician assistant. I have my co-host with me. Her name is Brittany. Welcome, Brittany.
Hey, Jeanette.
All right. So I'm a little bit anxious about this episode because I get so many questions about it all day long. And I truly felt that, honestly, before I started women's health, I didn't know enough about the pelvic floor. And just being a PA in women's health, I have learned so much about the pelvic floor. And what I'm most excited about is that we have a guest speaker today.
Yes, we love guests.
I
because
do.
no, let me tell you why I love it.
Okay, I'm ready.
My voice is so annoying, and and yours is okay, but like sometimes it's annoying too.
Oh my God, you are terrible. Whatever.
I'm just
You know
kidding.
what? I am going to just to say it. I've had so many people, including some of your best friends, that say my podcast voice trumps your podcast voice.
Oh no, I can openly admit that I don't think I have a good podcast voice. So there's no lies told there. That's very true. But
Okay,
yeah,
well.
I'm excited about the guest too. I think that's great.
Yes. And she's actually a physical therapist who specializes in the pelvic floor. So she's going to be great. Her name is Amanda Frank, and she's a physical therapist, PhD, and she's got a lot of experience. And she's going to basically teach us a lot of stuff that we probably don't even know. And I hope that their listeners learn so much and are not afraid to go and get therapy if they feel like they need it.
Definitely. Before we start, would you like to touch on what happened to you last week?
Oh, wow. You're going to bring this up. You're just going to go into it, aren't you?
Well, I felt like it could be a point.
Okay. So
let me start from the beginning.
Okay, I'm ready.
I get a text message last Friday from Jeanette it was around 6 a.m. and it says, "Good morning. Are you up?" Ladies, gentlemen, anybody listening, if you get a text message from someone that says that, I think there's like immediate like, something has happened. So that was my immediate thought. So I immediately called Jeanette.
Yes. And no, everything was not okay. It was not okay. So I'm sitting there getting ready like I normally do at this ungodly hour because I get up way too early. And I'm putting my makeup on and I look down on my phone and I've got a message on the Lube Tube Instagram. And I'm like, oh, that's exciting. And it's from I'm not going to say that, like who it's from, because I feel like that's kind of inappropriate, right?
Yeah.
I shouldn't say it. So it's from, I guess, somebody who follows our Lube Tube podcast / Instagram. And I'm like, oh, let me open this message up. I don't know why somebody would be sending me a message at 5 a.m., but maybe they've got some questions to ask. So I open it up and it's this cute little white heart. And I'm like, oh, that's nice. And I write back, hi, happy Friday, right? Just because, hey, it's Friday. I'm excited. I'm sure they're excited. I don't get a response, but like, I don't know, 5 seconds later, the video call starts ringing. I don't know if you've ever video called on somebody on Instagram, but it's a lot like FaceTime, right? And so it says, so-and-so wants to video chat. And I'm like, this is weird. Why would somebody want to video chat me at 5 a.m. in the morning? Maybe they have menopause questions.
At 5 a.m., Jeanette, this is great. Definitely.
I am so gullible. I never thought I was a gullible person, but obviously after this experience, I'm totally gullible. So what do? I open it up because I'm like, you know what? I'm here to help these ladies. I'm here to fix their problems and I am here to guide them, right? So I open it up. Ladies, do not ever, and I mean ever, open a video of someone you do not know calling you, okay? And I think that's probably something that I should have already known at 41 years old. There is this man pleasuring himself on the other end of the freaking video call.
Ouch.
Brittany, I about freaking died. Oh my
Block,
God. I
report.
could not press end call as fast as I possibly could. I could not press it fast enough.
Yes. And that is when we learned that Jeanette is kind of She's still learning. Yeah,
I'm
she's
still learning.
She's still learning.
You know, I look back at that and I'm like, what the hell was I thinking?
It's okay. We all learn lessons. Isn't it the saying, like, you learn something new every day? So that's
right. I learned a lot that day.
Yes. Okay. Enough of this. Let's go pelvic floor.
Okay.
All right. So I'll go first. Let's just say one thing. I actually had a patient today who came into the office and said, "Hey, I've been listening to your podcast and I think it's great, but can you talk about what happens after you have a baby and you can't control your pee?"
Yeah.
Things just feel different. Absolutely. I really think and I said, you know what? It's coming. So
literally, yeah.
And insert pelvic floor.
Yeah. So pelvic floor, what is the pelvic floor? The pelvic floor is just a big group of muscles that holds all of our pelvic organs in place, right? So we have pelvic muscles that line the floor of our pelvis that hold up our uterus, our bladder, our ovaries, and they just basically keep everything where it needs to be, all tucked in nicely. Well, things like babies or gaining weight or straining for constipation or certain things can cause your pelvic floor to weaken, right? And when that weakens, that's when we start having symptoms. Most common one that we are going to experience is peeing on ourselves when we sneeze, laugh, or cough, right? Or get scared or jump on a trampoline or, I don't know, even run, right? Exercising. I've had so many ladies that literally don't feel comfortable exercising anymore because they are going to pee on themselves. And I'm sorry, but wearing a pad to exercise is not very comfortable. So I do think this is a huge thing that not enough people talk about. And I think it's a huge thing that we educate these listeners on because, like I said earlier, I didn't know enough about it until I started, women's health, right? And I'm seeing it every day. And so the goal of this episode is basically to get you more comfortable talking about it, but also to educate you on why you're peeing on yourself when you sneeze, laugh, or cough, or if you can't hold your urine. So say you get to the point where you're like, I got to go. If I don't go now, I'm going to pee on myself. So that's two different types of incontinence, right? That's stress incontinence. Stress incontinence is when you sneeze, laugh, cough, get scared, jump on a trampoline, any of those, and you urinate on yourself. Whether it's a little bit or it's half your bladder or your whole bladder, you're still urinating, right? And then there is urge incontinence. Urge incontinence is more where if you do not go to the bathroom, as soon as you feel like you have to go to the bathroom, you will be urinating on yourself. And those are two separate things, right? And they a lot of times are treated differently. So options are pelvic floor therapy. There are medications, right? But our main goal of treatment today that we're going to talk about, especially with Amanda, is pelvic floor therapy. The other thing is people can have a mixed incontinence where it's both, right? Where they have one plus they have the other. And that's the lady I feel really sorry for, right? Because she's just not controlling that bladder, right? And as that bladder basically falls down a little bit further in that pelvic floor, it is like a water balloon. And the more pressure you put on that water balloon, it's going to squirt a little bit of water out if there's a little leak in there, right? And so I do think that kind of explaining the function of the pelvic floor can be helpful, but also knowing just basically how it supports the bladder, the bowel, right? That's another big thing. I mean, I hate to say it, but sometimes ladies even have fecal incontinence too. Talk about embarrassing. We think urinary incontinence is embarrassing, but fecal incontinence can also be an issue. And, sometimes it takes surgery for these ladies to kind of help with that.
Right. So we talked about the urinary incontinence that can happen when there's pelvic floor issues, but there's also other things that maybe aren't as common, like the pelvic organ prolapse.
Yeah.
And painful intercourse can certainly happen. Then there's just chronic pelvic pain. I mean, I was having pelvic pain. That's why I had to go in and do my pelvic floor assessment that, if we remember, was interesting.
Remember, you didn't know that she was actually going to go into your pelvis, and then she told you that you didn't know how to do a Kegel.
Right.
I bet none of us know how to do Kegels.
Well, I want a little, that's something I want to talk to Amanda about is explain what a Kegel really is. Because again, I think that there is a lot of miscommunication, misunderstanding, all the things when it comes to Kegels. So So I guess the postpartum wise, we certainly can have some recovery challenges,
Sure.
after you've, had a vaginal birth
Right.
and are really dealing with some laxity that is not great.
Well, honestly, even after if you were to have a C-section, right? Even having a C-section can lead to you still having issues with the pelvic floor because you held that pregnancy up for, almost 9 months, right?
Mhm.
And when that baby, as it gets bigger and bigger and bigger, the pelvic muscles can only do so much, right? And in this situation, they become weakened and they are not able to do what they used to be able to do. But you did mention earlier something called pelvic organ prolapse, right? Wow, this is a really, really big deal, and it can be extremely embarrassing for a lot of patients, right? This is actually where the uterus, right, or the bladder or the rectum actually fall through the vaginal opening, right? And wow, I had a lady actually just yesterday that came and saw me for urinary incontinence. And when I did her exam, I literally, when I had her bear down and push, because that's a way that we can kind of assess your pelvic floor and how strong it is, her bladder, you could see it protruding through her vaginal wall, right? And you could see it coming out. And it's literally looked like it was sitting right between her labia. And she feels this constant pressure all the time, like she's got something in between her legs, right? And honestly, for her situation, surgical management would probably be the best, but she did not want to go that route. Another option for her, she has actually tried pelvic floor therapy, but in her situation, it was to the point where it was too much, right? And so in her situation, she could also possibly do a pessary. A pessary is basically like this little insert that women actually we actually insert it for them. It goes inside the vagina and it actually holds everything up in place and they keep it there, right? It stays put. And we use vaginal estrogen cream in order to keep that tissue kind of moisturized so that doesn't irritate the skin inside. And these ladies usually come and see me about every 10 to 12 weeks, depending on the patient. I remove it. I flush the vaginal, basically the vault, and I clean everything out with some water and hydrogen peroxide. I clean the actual pessary myself, and then I replace it back in. So that is an option. That's kind of an old school option. They are still used, but not as common as they used to be used.
Did you know that you just used the word vault?
Oh, yeah. Vaginal vault. You like that word?
It sounds a little intimidating. Like, do we need a code to get in?
You know what I think about when you say vault? Olympics and Simone Biles.
Oh my God. This just goes to show how our minds are completely different. Like completely different.
Completely different. Hey, now we can tag Simone Biles though. She's got a pretty big following, I'm just gonna say.
She does. But her husband didn't know who she was. I still don't believe that.
I don't believe
it. That's wild.
Anybody in the world knows who Simone Biles is. I mean, come on.
Yeah. I will tell you, when I first heard that whole story about Simone and how he didn't know who she was when they first connected, I immediately put a sour taste in my mouth and I didn't know what to think about her husband.
Yeah.
And again, this is so ridiculous because it's all like he said, she said. Actually, he literally said that. But either way, then you watched her documentary. We've been talking about documentaries. And you actually are like, oh, he's a good guy. He
just, such a good guy.
Supports her, Yes,
I watched that one. Can you believe it? I watched that one. Yeah, because I really think she's freaking awesome. Like she's just this powerhouse, right? Oh, and I want to tell you, I started the Martha Stewart documentary.
Okay, good.
What a badass.
Uh-huh.
Oh my gosh.
Yeah.
Like, I mean, I could go off on just the first episode that I watched, but holy smokes. Like the fact that she just came from absolutely nothing and created this, like, I don't know, she created herself, right? It's kind of cool how she just made herself.
I bet she does pelvic floor therapy.
Oh, 100. Yeah, I bet she has her own that comes into the house and does, whatever that she needs to have done, she comes and helps her.
Absolutely. Let's talk about like the signs of, hey, maybe therapy is something that I need to do.
Okay.
I know we've mentioned the pressure. You were just talking about the pressure that could be the prolapse, but let's talk about the other ones.
Yeah. So if you're leaking urine, obviously, like we talked about, if you're having pelvic pain during intercourse, right, where sex never hurt before and now it is hurting, a lot of times that could be the vaginal dryness that we talked about, where we treat that with vaginal topical estrogen or hyaluronic acid suppositories. But this could be also something else, right, where you might have a pressure point in that pelvic floor that needs to be released. And a pelvic floor therapist can absolutely help with that and try to basically find out what is exactly it is that it's causing your issue. A lot of times it's also pain in the lower back, or in that lower hip pain, sometimes even in the tailbone. And a lot of times, depending on how big your uterus is, or, where the uterus sits, whether it's anterior or posterior, meaning like if the uterus is tilted or not in your pelvis, can cause different symptoms. And that can be just with your period, or it can even be pelvic pain alone, or even painful sex. So depending on the shape, the form, and the tilt of your uterus, it can also cause some pelvic pain that a therapist could help with that as well. So I think these are the main causes that bring women to see me. And I think Amanda will be able to shed light on some of the other things that, she finds and the reasons that she thinks that we should come see her. After talking to her a little bit, there are so many reasons that I should be referring these ladies to her more, and the amount of things that she can help. The other thing that I think is really cool is that she mentioned that she also treats males, right? Like erectile dysfunction, right? So she's able to kind of help with that, which I think is so crazy.
Fascinating. Wow.
Right? Also, benign prostatic hypertrophy, or BPH, right? Where the prostate's enlarged and they're having issues where they actually can't get the urine out. I read a little bit about pelvic floor therapists, and they can actually help with that too. So I just thought something like that is kind of interesting because, these males aren't going to seek attention. And of course, it's going to be really hard to get them to go to a pelvic floor therapist. But I think it's neat that there's such a great amount of stuff that they can do to help patients out.
Definitely. And what's also something to touch on is, pelvic floor therapy has been around for a while, but I feel like in the last 5 to 10 years have just had it's blown up, right?
Yeah.
And when you think of therapy, I think people think physical therapy and occupational therapy and so forth. Mm-hmm. With pelvic floor therapy, there could be like manual therapy. There can also be where they're using the like electrode. Is it electrodes? I can't even say the word.
Electrodes.
Electrode.
No, electrode.
Okay, so now we have an accent. And there's other exercises that can be given, and lifestyle changes too. So it's all encompassing. That's what I'm trying to get across. Is it's not just like I'm a physical therapist specifically for your pelvic floor. They bring it all together. So that's good to know. And also, we've been talking a lot about things that can happen when you've had a vaginal birth or, like you said, a C-section. But this also applies to women that have never experienced childbirth. I mean, there's
and I
still...
think, absolutely. And like you said, I think that a lot of times everybody thinks, I haven't had a baby, so it can't be my pelvic floor. Well, that's not true. I mean, like we mentioned earlier, even weight gain can cause a pelvic floor weakening, constipation, and also constipation can be caused by a weakened pelvic floor, right? So yeah, go ahead, Brittany, throw me under the bus. So in case you wanted to know, I deal with chronic constipation, and Brittany, my sister-in-laws, plural, are really like, hey, can you get your shit together, literally, and go see the pelvic floor therapist? Maybe I should just make a consult, because everything I'm saying right now is maybe something I should go get taken
100%. Truly. I'm glad that you're having an awakening, and this sounds like a good, because here's another thing that I
is this an intervention?
Know happened for me is I was trying to, and this has nothing to do with constipation, but I was trying to figure out, why am I having this pain? And this, even though I went there and it had nothing to do with my pelvic floor, it was nice to kind of check that off the list and be like, okay, so it's not my pelvic floor. Let me move on to the next. You have literally checked off every box.
You're right.
So pelvic
including
floor would be another one. Yeah.
Yeah. And it sounds like that's a lot less invasive than a colonoscopy, which
Oh
I've
my
already done.
gosh. Yes, absolutely.
I'm ridiculous.
Oh, so let's move on a little bit. Let's talk about like the emotional side of this, because obviously this takes a toll, right? When people are having these issues, there's a little bit of shame, as a lot of women's health things cause shame. There's obviously the embarrassment, and then there's like the fear. Like I'm not trying to look at you, but
yeah, but you are.
It's kind of the fear of the unknown. Like, is this what's causing my issues? Is this going to help, or am I going to just like go down a rabbit hole for no reason?
Well, and I personally can absolutely say that I have, like you said, I've tried everything else, literally everything else. I've tried prescription management. I've tried over-the-counter management. I've tried all kinds of things to help. The last thing I need to do is pelvic floor therapy. And one of the biggest things is I didn't know enough about it. And like I mentioned earlier, I had no clue that this was even an issue or a thing, right? For a very long time. And recently, the more I've learned about it and the more I've met with pelvic floor therapists and more I've talked to pelvic floor therapists, I've realized that, hey, this is definitely something that could be my problem. And it's not really an embarrassing thing for me. It's more of like, oh shit, I just need to make time for that. So I think there's also that portion too for women is like, oh my God, I have to make I have to carve out more time for myself to take care of myself. And we're bad about it as women, and especially healthcare providers. We're terrible about taking care of ourselves, right? But I do think that normalizing the conversation about it, and that, hey, sex shouldn't really hurt, and you shouldn't be super constipated all the time, and you shouldn't feel like your vagina has a huge bulge in it, right? Like all of those things need to be addressed, and there should be no shame in it. So bringing it up to your provider is obviously a great idea.
Right. And more providers are starting to see the importance of pelvic floor therapy. So I think that when you bring it up to your provider, 5 years ago, I don't know that every provider would have really even known what it is.
No way.
But now I think it's way more widely used, which is great to see. And if it's not being brought up by your provider, I think bringing it up is not a crazy thing to do.
No, not at all. And I think that normalizing the conversation and realizing that there's no one size fit all treatment either, right? So that physical therapist will be able to examine you, take a history, and figure out what your problem is in order to try to fix it, which is going to be different than mine, different than Brittany's, different than, any other girl that walks into her clinic.
Definitely.
So let me introduce her a little bit. Amanda Frank is a physical therapist with a PhD, and she is the founder and owner of a physical therapy clinic here in San Antonio, Texas, and it's called Uplift Physical Therapy. She is a provider who really does a holistic approach to try to help women and men of all ages with pelvic floor therapy. And so we decided to bring her on today and kind of chat a little bit with her and just kind of see how she kind of goes about her day in helping women and what she would recommend as far as treatment. And then also just talking about the common problems that she sees in her clinic. So I'm excited. Let's go.
Also, Uplift, like genius, Amanda, genius.
Genius. I know. What a great name. Like in so many ways, right? So yeah, I'm excited to have her talk to her.
All right.
So let's do it. So ladies, this is Amanda Frank. She's a physical therapist and is the owner of Uplift Physical Therapy. So welcome to the podcast.
Yeah, thanks for having me. It's great to be here. Thanks.
Absolutely. Brittany and I were kind of discussing a little bit about physical therapy as far as the pelvic floor and how the pelvic floor is so important, and it's responsible for a lot of things that we go through as females when it comes to incontinence or pelvic pain with intercourse, or even pelvic pain in general. The feeling of like that bulge in the vaginal or vulval area. So we thought maybe that you could kind of give us some insight on kind of what a typical day looks like for you. Also kind of when you see a patient for the first time for these different diagnoses, and kind of how you assess and kind of your plan going forward.
Yeah, absolutely. So pelvic floor physical therapy is something that's, I feel like, come about more recently within like the media. People are talking about it. There's a lot more just like coverage on pelvic floor problems, because the pelvic floor used to be something that nobody talked about. It was this like taboo topic that if you had a problem down there, you just had to live with it. There was no solutions. I even remember myself after I had my first kiddo, I had a prolapse and I was struggling with it, had so much pressure, so much discomfort. And I remember asking like my mom, hey, like, is this normal? Like, what is this? And she was just like, oh, honey, you had a baby. It's fine. And that was just considered like the norm.
Yes.
So
yes.
after all of that happened, I went to my OB. My OB, unfortunately, was not very informed on the topic. And he was like, yeah, just give it some time. It'll get better.
Oh.
And told me like not to lift weights ever again and never to do exercise. And I was like, this is not real. This can't be the answer. So I transitioned from orthopedic physical therapy, where I did knees, hips, backs, into pelvic floor therapy to try and help myself, but then also help all these other women. We also treat men, but help these other women specifically that were struggling with similar issues to what I had. So that kind of got me into pelvic health and starting Uplift and all of that. But as far as like, what do we actually do as pelvic floor therapists and like, who do we help? So we can help men, women, individuals who have penises or vaginas, either way. And we can help them with a lot of stuff, right?
Right.
So like you said, stress incontinence. So that's where if you are like coughing, sneezing, laughing, jumping on the trampoline with your kids at Airtopia, like those kind of things. And you're like, oh no, I peed a little, right? That pees where you peed and sneezed at the same time. That's
a great name.
Yes. So that's considered stress incontinence. It's just this increased pressure down on basically within your abdomen, and your pelvic floor isn't able to hold it up quite as well. Basically, it's kind of this war where you just can't support yourself very well with the muscles of your pelvic floor. Or we have urge incontinence. So that's more of that. Remember the commercials? Maybe I'm dating myself, where it was like, gotta go right now. Gotta go.
Yes.
Gotta go. And it's like lady like running really quickly after she put her key in her car or into the door of the house because she had to get to the bathroom. So it's more of this, like, sometimes it's like a psychological trigger where you're like, okay, I put my key in the door. I know I'm going to be able to go pee soon. But then the brain learns it kind of in reverse and you start going pee before you make it to the bathroom. So that's more of this like urge incontinence. You can have a mixture of both, which is unfortunate, but we treat them a little bit differently depending on the issue. And then there's other conditions as well.
Sure.
I've gotten to your actual original question.
No, I think I love it.
We do this all the time.
Sorry.
We have a question and we answer it, but then we have this sidebar that just leads us way in the wrong direction. But you did, I actually thought that you were right where you need to be. So
my biggest concern whenever I mention this to patients about like, I think that they need pelvic floor physical therapy is that they're so scared because they don't know what's going to happen. And when I tell them like, okay, well, I'd like you to go see her. I'd like you to go get evaluated by her so she can figure out a plan for you to strengthen this floor again. Is their biggest question is like, well, can I just do Kegels? Right. And so that's every time I recommend that. And then they get very nervous about what your exam is going to look like.
Right.
So can you kind of help us and kind of talk to us about what that looks like?
Yes, absolutely. I will say that it is totally normal to be nervous going into something that you've never experienced before, right? Super normal. We have patients call us all the time with this exact same question because it is kind of scary. Most people have had like their only like internal or like vaginal examinations have been when you're delivering your baby, when you're getting a pap smear, if you might have STDs, like things that are not always pleasant, right? Like getting a speculum put in doesn't usually feel great.
Right.
It's gotten better with different speculum types and warming the lubricant and, all those things. And then, you're usually there's such thing as like white coat syndrome, right? Where people just get nervous when they get to a doctor's office.
Right.
Stirrups aren't that comfortable. And then I don't think anyone feels good when they have somebody with like a bright, bright light shining in your hoo-ha, right? Like
no kidding.
Like it doesn't, I don't know. It just makes you feel real self-conscious, right?
Right.
Okay. So all that aside, in pelvic floor therapy, so something that we really strive for within Uplift, within our clinic, is to create this like warm and welcoming environment that doesn't feel super sterile like a doctor's office. Like it is still clean, right? But it is not like this, like everything's white. Like we have cushioned tables and there's no stirrups. That's a big thing. And we don't use speculum at all. Mm-hmm. So those are like the kind of two key points that most people, when we tell them that, they're like, oh, okay. So it's a little bit better. You know, people don't have to take off all their clothes, right? Mm-hmm. We're not doing breast exams or anything like that. So as far as a typical exam goes, you know, you fill out some intake paperwork. It's not just this huge packet. Like it's very specific that will actually inform us about your history. So it gives us kind of a jumping off point. Then you'll come in, you'll get a little tour of the clinic. We'll show you, hey, this is the room you're going to be in. Here's our gym in the back where we'll help you exercise and get back to that. We'll offer them to go to the bathroom. And then the actual exam, the therapist will bring them into a room and the therapist will really just have this like conversation with the patient. And it's really, I mean, it's like usually like a 15 to 20 minute conversation with the patient where we're getting to know you. We're getting to know what are your goals? What do you actually care about? Why does this leakage matter to you? It's not just that, hey, I leak and like I have to change my underwear. It's, hey, I leak and I'm worried it's going to smell and that someone's going to notice and I'm going to be embarrassed by it. And then people are going to think I'm the stinky person. Right? It's not just I'm peeing my pants. It's always something more. Mm-hmm. So we'll really take time to build rapport with you, get to know you, and fully understand your history and all the pieces. Mm-hmm. After that, we will get consent and we'll talk through what an internal exam would look like. You don't have to do an internal exam, right? There's still a lot we can do externally. The internal exam just provides another piece of data.
Sure.
So for the internal exam, what we would do is we would step out of the room, they would undress from the waist down and just lay on the table with a sheet covering them. So their legs are supported, they're not in stirrups, but they're just laying flat on the table with a pillow. And then we'll come back in. We usually have like soft music playing or something. So it's just a little bit more relaxed. Calming. Lights are a little bit more dim. The overhead lights aren't on super bright.
Right.
And with their permission, we will like lift up the sheet and just kind of look at their skin, right? Because I feel like tissue health is really important, especially as we approach like perimenopause and approaching any type of like, if they're breastfeeding or lactating, sometimes that tissue health can really break down. So we just kind of look at it and we're like, okay, is it really red? Does it look raw? Does it look dry? And then after that, we'll just push lightly with gloved hand and all that. We'll push lightly kind of on the outside on the muscles. So we're not going inside yet. We're just pushing on the outside. And we're just asking the patient the whole time while we're looking at them, like not making awkward eye contact, but just like talking to them. And we're like, hey, like, is this tender at all? How does this feel? Any issues here? And the patient's just chatting with us about like, oh, ow, that's my pain. It's not really that tender, but like if they had discomfort, they could tell us. And then with their permission, we would insert one finger with lube on it, again, with a glove, vaginally. And when we're inside vaginally, we're able to actually feel the muscles of the pelvic floor. So you'd be surprised. Like a lot of people think that the vagina is just this like tube and that's it.
Right.
The tube goes through a hammock of muscles. Mm-hmm. Right. So what we're doing is the tube is kind of our access point, and then we're getting over to the rim to the hammock of muscles to assess, is it tender? Because some people have a too tight pelvic floor and not a weak. We kind of have two categories. We have like the weaker pelvic floors and then like the really tight pelvic floors. And a lot of people are like, well, why can't I just do Kegels? Will that fix my problem? If you have a too tight pelvic floor and you just keep contracting it, you're going to get tight. It's going to hurt more. It may cause you to leak more. Versus if your pelvic floor is pretty weak, first we need to make sure you can do a Kegel correctly, which most people aren't.
Thank
We've
you.
talked about this.
I have one question for you.
Yes.
I'm sorry to interject, but
No, you're good.
I had an assessment with a pelvic floor therapist, and I'm so glad you're explaining all this because I went in very naive and had no idea that there was going to be a pelvic exam. And I got over it, obviously. But one of the things that she did ask me was to perform a Kegel while she was there, waiting for me to do it. And I thought I did one, and she just kept looking at me like, but are you going to do it? So I think there's a huge misconception that people think they're actually doing it, but they're not. So is there like a secret or any like tips you have for people to do a correct one?
Right. So in the literature, the cue that seems to get the most people to do a Kegel correctly is to wink your butthole.
Oh my, I love it.
So it's like, or squeeze your anus is another way that you can do it. But the idea is not squeeze your butt cheeks, right? I'm not like clenching. You're trying to just make it wink a little bit. That is probably the easiest cue, but it doesn't work for everybody.
Right.
Other people, we will, give the cue of pretend there's like a blueberry sitting in front of your vaginal opening and pick it up with your pelvic floor and with your vagina. Obviously, don't legitimately use a blueberry and pick it up. It's a great way to get like BV or some infection, something like that.
I am so excited about these hashtags right now. That's not even
right. There's so many things that we say, I feel like every day within the clinic that are just like, what?
What did you that honestly what you said conversation. But on the Lube Tube, you can say whatever you need.
Right. Nothing's too much. It's all weird. Yeah. So doing either like winking the butthole or picking up a blueberry with your vagina. If you have male genitalia or a penis, thinking about turtling your penis. So just kind of like making it go like
interesting.
Or bringing it on like an elevator and making it like jump is another way to like get it to move. But they have buttholes too, so they can do that as well.
Yes.
It's doing a Kegel is hard because most people think it's this really complex movement. A lot of people squeeze their butt cheeks, they tighten their abs, they hold their breath, like they do other things, not just a Kegel. And that's where we run into some problems because some of the time they're just squeezing their butt cheek and their pelvic floor really isn't doing anything. So they think they're strengthening their pelvic floor, but really they're just like getting their butt tighter. I don't know. Like it's not effective. So I think getting an assessment with an actual, like either finger or some type of like biofeedback, something that's telling the person like, yes, that is a good squeeze and it's a good lift because it's not just the squeeze. We have to get the full range of motion of the pelvic floor, not just this little tiny, squeeze. So, but great question. Yeah.
I've been waiting to ask you this question. So it's been months now.
We can check later. It's fine.
So one thing also, we just spent some time talking about Kegels because I feel like that is something that's been like in the media forever.
Yes.
But what are other ways that other treatments, I guess, that you do to fix the pelvic floor issues?
Yeah, absolutely. So Kegels, if somebody has a pelvic floor that's weaker or just not very coordinated, meaning we go to fire it and it's just kind of this like quivery jellyfish, it's not actually like giving us good lift. We're going to start with like more Kegel based things or some global like hip strengthening, butt strengthening, those kind of things, because there is some overflow. So if somebody can't do like there's a pretty strong correlation between like hip strength and pelvic floor strength. So if we can generally get hips to be stronger, so like hip thrusts, glute bridges, deadlifting, any of those kind of things, their pelvic floor should come along for the ride as long as they're not like bearing down a lot as they do those activities. So doing strength training is kind of like a starting point. But we want to kind of transition out of the Kegel only zone pretty quickly because Kegels are this tiny little muscle. It's not going to globally help usually. So we need to do more than that and get off the table, not just do stuff on our backs. We need to do things standing up. We need to do things in hip hinging positions, just really because we don't live life on our back. So you need your core to function in all sorts of different positions. So as far as like strengthening goes, that's how that like a treatment path that we go down there. But if a patient is having a lot of like pelvic pain, a lot of tightness, if there's high tone in their pelvic floor, like gripping, think about if you're like clenching your jaw really hard, if their pelvic floor is kind of like that, then we need to do actually more lengthening in the pelvic floor. So that may involve some like manual hands-on therapy where we're able to I don't want to call it a massage of your pelvic floor because that's not like that, but some just like trigger point, like would be push on a spot in your pelvic floor that's really tight. And then we have you do maybe some Kegels or some breath through that until that muscle area kind of melts. Think about like you go to a massage, you get your upper trap kind of worked on up here, your neck, and they push on a spot. And then eventually it kind of relaxes. Same idea, but in the pelvic floor. And we also get your breath to work with it because your diaphragm and your pelvic floor kind of move together. Mm-hmm. But it really just depends on kind of what camp the patient's kind of falling into, what's their main complaint, and what did we find. But Kegels are definitely not the only option.
How often do these ladies usually have to come in for treatment? Is it like a couple times a week and how long does that treatment usually last for them?
Yeah. So it's very dependent on, at least in the literature, it's very dependent on like what their condition is or what they're in with. The recommendations for stress incontinence is once a week for 12 weeks is the actual recommendation by the NICE, which is the National Institute for Health and Healthcare and Excellence group out in Europe. So they come out with a lot of incontinence research and literature. And so their recommendations is once a week for 12 weeks. And then for prolapse, it really is very dependent on the degree of prolapse. Is there surgery involved? Things like that. If it's like scar tissue management. So if somebody had like a C-section or something like that, it's a little bit less time. So maybe like 6 to 8 weeks of care. It really just depends. I would say pelvic pain with like a lot of tightness usually needs more treatment because it's typically a chronic condition where we almost need to get a good baseline and reset everything and then manage the flares so that we're trying to be like, okay, if your flares are really violent or volatile, and we can get you so your flares are less frequent or your flares are less intense. And we want to make sure after a couple of rounds of potential flares that things are leveling out and feeling better. So it's very patient dependent, but I will say it's not a 4-session fix.
Got it.
What would you say that, and this is kind of a broad question, but what is your, I don't know, success rate? That's kind of, like I said, it's pretty broad, but how often do you see a positive change? And obviously, are there times where, pelvic floor therapy, you can do it and maybe just not get exactly what you want out of it?
Yeah, absolutely. So I'd say most patients experience positive changes around the 4 to 6 visit mark. If they're consistent, they're doing their homework, which we don't overload them with homework, but doing things at home, they're coming into the clinic, they're staying, compliant. Usually around 4 to 6 weeks, we start to notice some tissue changes. As far as strengthening goes, it does take about 8 to 9 weeks for actual true muscle change to occur. So that's the hardest part is that if somebody stops therapy right when they start to feel a little bit better, so they stop around like that 6-week mark, maybe, they are likely to kind of relapse back because they didn't actually get all the way stronger, right? They didn't maximize their like resilience of their tissues, if that makes sense. But for the people who make it and they do the resilient work and they get to the point where their body is just like totally ready and solid, like those people generally do amazing and they don't relapse. They don't have to come back that much for like tune-ups or anything like that. I think so the research for like stress incontinence, urge incontinence, those two, especially pelvic floor physical therapy is considered the frontline treatment for it. It's considered like the thing that people should do before trying surgeries, before trying a bunch of medications, things like that, because the evidence is there to support it. For people to get better. I think it's the chronic pelvic pain patients, interstitial cystitis or bladder pain syndrome. Pelvic floor therapy is still the first line recommendation based on the more recent recommendations, but it's usually a multidisciplinary approach for some of those patients that are just a little bit more complex. Prolapse patient, or patients who have prolapse, kind of the same thing. We need to know, okay, what's the stage of the prolapse? Like, is it coming all the way out where now we need to talk like surgical or pessary intervention? And so sometimes like we can get them to where their symptoms are more manageable and feeling a lot better, but is it going to change their prolapse stage?
Right.
There's not evidence to support that we're going to change the stage of the prolapse, but we can usually change the tissue sensitivity.
Awesome.
What about like myths and misconceptions? Is there anything that comes across with, new patients that have been there a while, or just, stuff that's also like in the media? Is there anything that you would like to debunk?
So I think we've already debunked the like Kegels are everything.
Yes.
That's like the number one, like
really?
myth. Yes. I think the second myth is that there's so many people that are afraid of exercising during pregnancy.
Yeah.
There's a lot of fear around that. And unless the patient is like a super high risk pregnancy where literally exercise is dangerous for them, which is not a huge percentage of patients who are pregnant. Unless the patient is like that, exercise is super healthy for the baby and for the mom, right?
Right.
It's great. And so a lot of people are afraid of that. And sometimes they just want a little bit of guidance on like, what can I do? What can't I do? So we can, we come alongside them and help them navigate that situation. And a lot of patients are also afraid of doing ab exercises when they're pregnant, which
they are,
generally speaking, are just fine to do. We just need to check and see like, what is your abdomen doing when you're doing this ab exercise? Is it too hard for you right now, or is it okay? And so I think there's just these blanket statements that go out about pregnancy and exercise and things like that are a problem. So,
do you take care of pregnant patients if like they refer to you for that like pelvic pressure, back pain, low back pain to help with strengthen that pelvic floor during pregnancy, like the late stages?
Yes, absolutely.
Okay.
Yeah, absolutely. So there's so much pelvic, sometimes like tension that comes along with carrying a baby, especially when you're getting towards the end of your, pregnancies, where you're towards the end of your pregnancy. And if we can get some more mobility within the pelvis, within the hips, within all of that, usually patients start to feel a lot better. And if they're having a lot of like swelling, so like varicosities, those type of things as well, there's some really great like lymphatic drainage techniques that we can do that can really help to offload kind of that system and just relieve some of that pressure and make them feel better.
Awesome.
Yeah.
Can we just talk real quick about biofeedback and how that's utilized? Because I feel like that's...
Yeah. So biofeedback is a controversial thing, I will say, within the pelvic health community.
Okay. Do you use it frequently, or like
I don't use it at all.
Yikes. I'm sorry for the question.
That's okay. No, that's okay. So okay, let me tell you why. All right. I think it's informative because this is a huge point of sometimes contention between OBs and some pelvic floor therapists. Cause they're like, I want this patient to do biofeedback. And we're like, we don't do that here. Yeah. So it's okay. It's okay. It's a great question. So what biofeedback is, one, a lot of clinics use biofeedback because insurance reimburses a lot for it. Let's just like put that in the corner.
Yeah.
Okay.
We love money.
There's some financial incentives. Also, you hook someone up to biofeedback, which for anyone who's listening, biofeedback is where they hook up these little electrodes either near your rectum, or they might put a probe that's inside of you, and you do some Kegels and you look at a screen to make the flower open and close to tell you you're doing a Kegel. Okay. The problem is that when you're hooked up to that, you usually can't do anything functional. You have to lay on your back. You can't move. You can't like do squats. You can't do a bridge because the feedback won't be accurate because the sensors will kind of get moved. So biofeedback can be great for the patient who has a pelvic floor that's literally doing nothing. Like the patient who maybe had an avulsion, like a levator avulsion, or the patient who their pelvic floor cannot figure out what to do. So using biofeedback just to get the initial pattern recognition of like how to do this movement can be helpful for like a couple of sessions. The problem is that a lot of clinicians were taught previously that biofeedback was like the thing to do. And they didn't progress people past it. They would only do biofeedback. So patients were like, well, I just laid on a table and they hooked me up and they like typed on their computer and didn't, like nothing got better. So it's a problem.
Yeah. Well, and I think that I shouldn't have asked that question. I mean, come on, Brittany, what's wrong with you?
I think it's a great.
Oh yeah. No, I agree. I good. Yeah.
So biofeedback has its place with the right patient.
Right.
We can provide manual biofeedback. So it's finger inside giving you cues. We're like, oh yeah, that was really good. Okay, no, maybe a little bit less. Okay, do a little bit more. But the thing is, we only need to do that for a little bit of time and then we move past it.
Yeah.
Right.
Yep.
We have to move past it because there's so many patients who come to us and they're so frustrated because they're like, I tried pelvic floor therapy and it didn't work. And we're like, well, what did you do? And they're like, I don't know. They like hooked me up to a machine and like told me to like do a bunch of Kegels. And they're so frustrated because it didn't do anything. So some people it's great for. It reimburses really nicely and you can work on your notes while your patient's on it. Is it the right thing for the patient is what it comes back to.
Got it.
Yeah.
Awesome.
All right.
She answered your question, Brittany.
I know, like really well. And I
may not have been the answer you wanted, but
no, I love
great.
it. I know,
it's great because it's true and it's real life.
Right.
Yes.
Well, and it's also nice because I mean, as providers, like we've learned about pelvic floor therapy, but like not to this extent. And so I knew that biofeedback is like involved, but I didn't know to what extent. And now I realize that maybe it shouldn't be.
Remember, it's not wrong. It's a way, but it might not be the way.
Yes. I love it. Thank you for the explanation.
For sure.
Well, thank you. I appreciate it. You've been so helpful. I know the ladies will truly learn a lot from this. So thank you.
Absolutely. Thanks for having me.
Okay. I love it. Why are you laughing?
Janet.
No, okay. It's not Janet. It's Jeanette, Bridget.
It's about...
Okay. I think we all have heard this, right? That she has basically gotten that entire clinic that we work at to call me Janet, patients included.
It just rolls off the tongue easier. Like,
well, I told you earlier that you say that way too easily. Like Janet just rolls right off your tongue.
At least I know your name starts with a J. That's fine. Speaking of J, you know what time it is.
Oh, slippery solutions. Yeah, Brittany, we still don't have a jingle.
With B&J, here we go.
These ladies have to listen to me. With B&J.
All right, we got two good ones. You ready? Number one, I recently got on hormone replacement. I now have my life back, specifically my sex life.
Yeah, girl.
Only minor issue. Traditional condoms have never worked well for me. I think I must have a latex allergy. What are my other options? Do you recommend anything?
This is a great question, right? Because I feel like ladies do not protect themselves because of an allergy or irritation that they get from specific types of condoms. I mean, I'm way out of the condom game, but I do know like the original ones that like the Trojans and what is that other one? It's called like Durex, I think is another condom company. Sometimes ladies can have a real significant allergy to these. There are lambskin condoms and oh my God. Okay.
They work though. Mm-hmm.
They do work, but they actually don't protect as well against the STDs as some of the other ones, just because of just how they're made. But there are some good condoms. There is a company specifically called Skins that I've looked up before. And Skins is kind of hypoallergenic and it doesn't have all of the irritations or the irritants in it. And it's more of a natural approach to a condom. And so I've had ladies that do a really good job or have a really good success with that specific brand of condom. And they have like all the different ones, like the ribs or the thins or whatever you're looking for. And I think they come in different sizes too. And last I looked, when I read about these a little bit, they do have them in department stores because there are some condoms that are hard to find like this, right? They're not going to just be at your drugstore, just easily found. But they do have some at Target.
Oh, okay.
That's where I saw
Nice.
them. So hashtag Target.
Hashtag Skins, not to be confused with Skims. Honestly, though, if Kim K was smart, she would have jumped on that.
Yeah,
because those are very similar. But
I know.
I digress. She's doing okay with her money.
Okay.
Whatever.
I think so.
Yeah.
I think she's doing all right.
Okay, so this next question is actually about a previous episode. There was a little question about it. So Here we go. In the last episode-ish, you said you don't recommend a blood test for herpes because if you ever had it, it will come up positive. And in parentheses, it says, I think. Does that mean if you have the virus but don't have symptoms, a swab test would come up negative? Asking because I met a guy on an app who asked me for an STD test. I had an outbreak when I was younger, but take Valtrex and have never had symptoms since. Can you please explain this more?
Good for you. Yeah, absolutely. So when we do a blood test, we check two different antibodies, right? We do an IgG and an IgM, okay? IgM is an antibody that is a recent antibody. So if you were recently around herpes simplex or were recently had an outbreak of herpes simplex, your IgM would be elevated. If you have an elevated IgG, which is your memory, right? It's the one that stays around for a very long time. It's the one that protects us from getting recurrent infection. That's going to be elevated if you had an infection a really long time ago or you've been around it, right? And most of the United States population has been around herpes simplex virus. So the reason why I don't recommend this blood work is because it doesn't tell you if you have an active infection and if you are going to be able to spread that virus right now. If your blood test showed that you were positive for IgM and you do not have a lesion, I swab you and I just swab the vulvar area or the vaginal area, it will come back negative if there is no rash there. So the only test that I recommend for herpes simplex virus is the actual swab itself if you have a lesion. If you don't have a lesion, there's nothing to swab and it will be negative. So moving forward with this new partner is I would just explain to him that I'm negative for gonorrhea, chlamydia, and trichomonas, but I do have a history of herpes when I was really, really young, but I've not had an outbreak since I was treated. And I think that's got to be something that he or she is okay with.
Good explanation, Jeanette. I know those IgGs, IgM.
Bring it out.
Oh my
Bring it
God,
out
that
of
was
the
that was so
brain.
sexy. Thank you. Yes.
Ooh, thank you so very much. Thank you so very much.
Okay. Well, thank you to Amanda. Amanda, we really appreciate you.
Yes.
You provided lots. I mean, I learned new things. So I imagine everyone listening to this definitely learned some new things.
Yeah, I just think that if you live in San Antonio, what a great person to go see.
Absolutely.
She makes you feel comfortable. She's got a great background. She's well educated and she's going to make pelvic floor therapy fun and take the anxiety out of it. Right. So We're going to put her link up to her Instagram on our Instagram. So if you could just go follow her, and then she's got a link on there to schedule an appointment for her through her website. So if you feel like any of this is something that you absolutely need to be treated for, or even just be evaluated for, I think you should go see her because she's freaking awesome. I refer to her all the time, all day long.
I have one more thing.
Okay, ready?
So I think when this comes out, it's this episode. It'll probably be after Thanksgiving if we're being realistic, right? As a woman, what is one thing we're super thankful for?
Oh my gosh, there's like a lot. Like, are we talking? There's a lot. I have a lot.
Okay, well, I said one.
Okay, so as a woman, I am so thankful that I was able to bear my children, because my boys are the best things that have ever happened to me. So that's the one thing I'm super thankful for being a woman.
I love that. I should have gone first because my gosh, can't beat that. You bitch.
You're the fucking one that asked the question. Okay, Brittany, what is one thing that you are thankful for being a woman?
I am thankful for the fact that people will open doors for me.
Oh, that's nice.
I am thankful for the fact that
Oh God, here we go, y'all. Who knows what this is going to come out of her mouth? Are we ready?
If I'm being honest.
Okay, here we go.
I am grateful and thankful that I don't have a penis.
Yeah, right? First of all, I talk about this all the time with Daryl. I'm like, how do you just walk around with that thing hanging in between your legs? And like, don't you sit on your balls or something? And doesn't that hurt?
Jeanette, do you remember from when we were children and there was this cartoon? Well, he wasn't a cartoon. He was a puppet. His name was Alf.
Oh,
remember Alf?
Had that big nose.
Yeah, that's what when I think of a penis, I'm just glad I don't have an Alf.
Oh my God. #Alf.
Oh man. But on a serious note, I'm thankful for you and this podcast and how fun that we get to do this weekly. And we still like each other and don't want to.
I know. And we still want to keep going. Like, I think it's so great. And I love that there's like this endless amount of conversations that we can have, and we can find humor in it, and we can make people feel comfortable and educate them at the same time. Yes.
Absolutely. Absolutely. All right, ladies and gentlemen, thank y'all so much for hanging out with us.
Yes,
happy belated, happy Thanksgiving. I don't know when this episode's coming out, but happy.
Happy all the things. And thank y'all so much. We're thankful for y'all. And thanks for just keep on listening. We appreciate it.
#Alf.
#peace. The information provided in this podcast is for general informational and educational purposes only, and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition. There is no provider-patient relationship formed. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. The hosts, guests, and producers of the podcast do not assume any liability for the application of the information discussed. Reliance on any information provided by this podcast is solely at your own risk.